Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and chief medical officer of NEI, Dr. Andrew Cutler, sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
There's no shortage of opinions about antidepressants, how they work, even if they work, and what risks they carry. In this episode, I'm sitting down with my good friend Dr. Jeffrey Strawn to unpack some of the most common myths and what the evidence really shows. And this is just the start. We'll also be tackling myths about antipsychotics and ADHD medications in upcoming episodes. Jeff, how you doing?
I'm doing well, and it is great, as always, to be here with you, Andy, and I'm ready to do some myth-busting.
Okay, myth-busters. Well, there is just so much misinformation, unfortunately, about many of our medications. And we're going to start here with antidepressants. And I know that you specialize in kids, but you see all ages. I don't think we should limit our discussion to just kids. Is that all right?
I'm so glad you said that. Although, Andy, I'd mentioned I am a general psychiatrist as well as a child and adolescent psychiatrist. So we're going to really talk about this across the lifespan here.
Sounds great. Well, let's start off with some general misconceptions. What are some of the misconceptions that you think are most common that you see with patients, families, or even our colleagues that seem to have the greatest impact on our treatment decisions?
Yeah, I think it really depends on what group we're looking at here. Now, scientifically, I think one myth, and maybe we can dissect these individually, is that antidepressants are no better than placebo.
Oh, yeah.
I think another myth is that if the first SSRI doesn't work, an antidepressant or pharmacotherapy for my depression or anxiety won't work. I think another one is that antidepressants change my personality or will change my personality or my child's personality. And then I'm going to throw in a new one, which is one that probably relates to pharmacogenetic testing, which is that pharmacogenetic testing will choose the antidepressant that will work for me. So do you want to jump in and we'll go through these sequentially? How do you want to do this?
Well, I'm glad you brought that last one up because like me, you do a lot of medical education, and I get asked all the time about genetic testing. What do I think about it? Is it valuable? Is it useful? So we'll get into that. But why don't we just knock them down? There is one other one I want to talk about, this notion that antidepressants somehow cause suicidality. So
that's a great one.
Yeah. Well, Jeff, why don't we just handle them in order? I thought that was a nice order. So let's get started with your first point.
Let's start with that first one, which is that they don't work more than placebo. Now, for me, saying antidepressants don't work better than placebo is like saying antidepressants don't work because colds are viral. I think we end up treating a lot of things with antidepressants that may not be pharmacologically responsive.
Okay.
So we know that major depressive disorder is pharmacologically responsive in terms of antidepressants. We know the same for OCD. But oftentimes when we're looking at many of our patients, they have other psychosocial issues. They may have personality factors that are driving this. They may have co-occurring anxiety that either influences the tolerability of the antidepressant or changes the trajectory of response. And so I think what we really need to do is think about how we're matching the treatment, whether it's an antidepressant or something else, with the patient, with the dose, with the duration. And really, if we look at the trials that we have, STAR-D, COMED, some of these very, very large NIH-funded trials that were now done decades ago, we see clear, measurable improvements well beyond what someone might attribute to an expectancy effect.
Yeah, no, that's a good point. I've been doing these trials, as you know, for 30 years, and we generally try to rule out comorbidities to some degree and rule out things. And we're trying to get patients who are what I call medication responsive, but it's not a perfect science. The fact is that giving placebo is not nothing. In a clinical trial, for instance, we see our patients for longer periods of time at more frequent intervals. For instance, Jeff, I want to ask our clinicians in the audience, how many of you spend 4 to 6 hours with your patient for your initial evaluation and then another 2 to 3 hours every week thereafter? Well, that's actually, unfortunately, how we do it in clinical trials. And so there's a lot of non-specific treatment, if you will, that goes along even with a placebo.
Absolutely. Yeah. Absolutely. And even just some of the things beyond time, like being able to appreciate a diagnosis or having that hope that there may be some treatment that actually relieves the suffering that I've been going through for a while. The other thing that I notice as I'm seeing patients in clinical trials is oftentimes when we do that structured assessment at the beginning or prior to a baseline visit, patients now start paying attention to specific symptoms.
They do.
And so we actually change the way that they're reporting and thinking about their symptoms in the clinical trial.
That's right. And also the informed consent process is providing them with way more information than they would get in a normal clinical scenario.
Absolutely.
And the fact that, as you said, we're paying a lot of attention to them, we're giving them care, we're spending time in doing a thorough evaluation. I think all of these things can, increase placebo response. The other thing over the years that's happened is who is going into clinical trials now? Well, it tends to be people who are not easy to treat. They would have been treated already because we have a number of good medicines out there. So now we might have a group that is less likely to respond to medicine. And then a really big one, you did mention dose and duration, which is important. It's actually very hard to predict a human dose, for instance, from animal studies. And I always say everybody gets dosing wrong. We just don't know how you got it wrong yet. But also something we need to talk about is the heterogeneity of the illness. The fact is that depression is a very heterogeneous illness, not only in how patients present clinically, but neurobiologically. And to think that one mechanism of action is going to work for everybody is a little naive. And unlike other fields of medicine, we don't have good biomarkers to match the patient's pathology to the mechanism of action of the medication. So all of these factors, I think, lead up to this. And I don't think that people should misinterpret a, quote, failed trial where a drug fails to statistically separate from placebo with a drug not working at all in any patient.
You're absolutely correct. I 100% agree. That second myth, I think it was the second one that we mentioned, was that if the first antidepressant doesn't work, medication won't work.
Yeah.
And I think this is really a problem with how we fundamentally conceptualize treatment. Depression care is a journey. This is not a single pill trial. And again, I've already gone back to the STAR-D trial, which I realize is a bit dated at this point, but I think that really showed us, again, that this is a journey. This is not a single intervention. It's really a sequence.
I agree.
And so what STAR-D, I think, showed was that remission, which really should be the goal of treatment, accumulates over the course of these sequential trials. And I think that's something that we often lose sight of when we're looking at our initial treatment in the moment with a patient in the office. So I often will tell patients it's like trying different keys maybe in a lock. The goal isn't to give up after the first key doesn't work, but to find the one that turns and is the right fit.
Yeah, I totally agree with you. And I think also the problem too is that sometimes we adopt a sort of good enough is good enough attitude. And I feel like sometimes we adjust our expectation to what our medicines can do. And because SSRIs and SNRIs, which are the most commonly used antidepressants, get people so much better, we've sort of kind of adjusted that as that's good enough. That's our goal, if you will. We have now, of course, lots of evidence-based things that we can do after the first inadequate response.
Absolutely.
But there's an implementation gap. Our friend Roger McIntyre is always talking about the implementation gap. We have a lot of evidence-based things, but unfortunately, they're not being done as often as probably they should be in the real world.
Yeah, and I would maybe even go a step further. And so I think this actually probably obliquely addresses one of the other myths that we talked about, which is pharmacogenetic testing, which we already said doesn't pick the medication. But back to your point, Andy, one of the things that I think we're still learning about is actually how to dose even some of these older medications. For example, when we look at something like sertraline, only in recent years have we understood that there is a 2B as in boy 6 contribution to sertraline metabolism. And it wasn't that long ago that we realized that there was tremendous variation that was attributable to 2C19. So again, that one dose doesn't fit all patients.
Well said. Yeah, I think that's a very important thing too, is to individualize your choice of medicine, your dose, your strategy, and to not give up, as you said. And look, if a patient is tolerating a medicine and you're not seeing the response, I would say keep pushing the dose. There's probably a point of futility, but it may not be the highest approved dose that's your point of futility. We've all had the experience of patients who really do well once I get the dose even a little bit higher than what's FDA approved.
I think that's a really important point. And obviously, when we look at some of those earlier studies, we didn't really appreciate a lot of this variation in metabolism that we now take for granted, quite frankly.
It's true. And I think there's many causes of variability in metabolism. We just happen to know a little bit about the cytochrome P450 system, but there's many other aspects, including PGP proteins, transporters, all kinds of other things like that.
Absolutely. And that's another podcast, right?
Yes, we got to do another podcast on that one. Okay, I do want to go back to the genetic testing because it is such a commonly talked about thing. I have to say I'm not totally anti-genetic testing. I don't think you are either. But I think this over-reliance on what it can do, the belief that it can magically choose the right antidepressant, I agree with you. This genetic testing tends to be a little better in general for pharmacokinetic information than pharmacodynamic, meaning how the drug works and what's the right drug, if you will. There are some of the tests that are helpful. But I think something we don't talk about, Jeff, and we have to be honest about this, is since we don't have a blood test or an x-ray to give to a patient or their family, the ability to hand you a piece of paper that has this writing on it that says...
It's seductive, right?
It is. And so I think it helps with buy-in. And maybe there's a placebo response. But you know what? In the real world, placebo is my friend. As a clinical trialist, it's my enemy.
Yeah. Placebo response is baked into all of our antidepressant response, our antipsychotic response in terms of our ADHD medications, although probably to a lesser extent there than in some of the other disease states.
Yeah, in the real world, it's placebo plus or drug plus placebo. You're right. And that's okay. Well, I think we have to address, too, the labeling and the terminology we use. I mean, the fact that these drugs are called antidepressant. Jeff, I remember in my residency, Prozac came out, fluoxetine. And I remember when we started using it for anxiety disorders and it blew our minds. We were like, wait a minute, this is an antidepressant, but it's working for anxiety disorders.
It probably works better for anxiety disorders than depression.
I think you're right. So unfortunately, these labels kind of put medications into a box and lead to some misunderstanding too.
Yeah, you're absolutely right, Andy, and I 100% agree. The issue is calling them antidepressants is like labeling ibuprofen a fever pill.
Yeah, that's
We
good.
know that it is anti-inflammatory. We know that it is analgesic.
Yes.
We know that it has many other functions.
That's right.
So these agents that we really call antidepressants, they turn down the amygdala, which is relevant for anxiety. They reduce error signal overdrive, which is important in terms of OCD. And they also affect steady arousal systems in terms of panic disorder, in addition to having the salutary effects on mood, which we see in terms of patients with depressive disorders, at least unipolar depressive disorders.
Well, our most commonly used antidepressants are a little bit of a blunt instrument, let's be honest. If you're an SSRI, you're increasing serotonin everywhere in the brain, and serotonin has wide-ranging effects, as we know. There's serotonin receptors all over, the pre- and post-synaptic. And so it's not totally unexpected that they might work for more than one thing. You know, Jeff, in my residency, it was so simple 30 years ago. You had a deficiency of serotonin in your brain, and all I had to do was raise serotonin and magically fix it. So that's another misconception.
The chemical imbalance.
Chemical imbalance.
Oh, let's go there, Andy.
Okay, let's do it.
Let's do it.
We used to think literally there was one part of your brain that didn't have enough serotonin. We've learned so much more about the complexity of this disorder and the importance of the connections between parts of the brains, the circuitry, the networks. And what we're really talking about is restoring some degree of regulation or balance, if you will. Chemical imbalance is too simplistic, I agree, but what would you say?
Yeah, it's just this notion that medications or antidepressant medications, if we're going to use the old moniker, pour serotonin into the brain somehow. They really probably help the brain relearn how to use its own neurotransmitters effectively. And when we're thinking about those disorders that are pharmacologically responsive to antidepressants, so depression, anxiety, OCD, probably some others. These are disorders that involve overactive threat circuits and underactive regulatory systems.
Well said.
And the SSRIs specifically really enhance that signal-to-noise ratio within those networks.
Nice, yeah.
And what we hope actually happens is that we see then healthier patterns that emerge over time. So it's really not about adding chemicals. It's I don't know, maybe retuning the orchestra or something along those lines.
Well, one of the things about how the brain's actually organized is there is a top-down regulation and a bottom-up sort of signaling regulation. And you said it well. The threat system is a little more primitive. It's our amygdala. It's lower down, if you will. And then, of course, higher up, we have the prefrontal cortex, which evaluates this information. And there's a talking back and forth. And if that gets out of balance, you'll overperceive threat, for instance, so you'll be underable to extinguish threat.
Absolutely. And I think, Andy, this question gives us probably a little bit of an opportunity to think about what antidepressants are actually doing, which I think can maybe take some of the uncertainty around side effects that we might expect or that are associated with other myths or myths around efficacy. So when someone takes an antidepressant, I'll just use that term since we seem to be stuck with it for the first time, yes, we do get an increase in serotonin synaptically. And that's something that probably happens within hours because of that blockade of that serotonin transporter.
Right.
But as you and I have talked about many times before, including on this podcast, when the brain senses that surge in serotonin, we involve multiple compensatory processes. And specifically, we have those 5-HT1A autoreceptors in the RAF-A, which immediately reduce neuronal firing. So in essence, what actually happens early on is that downstream transmission dips a bit. And that's why oftentimes many of our patients with the traditional antidepressants don't feel that immediate sense of relief that comes with a abrupt change in terms of serotonergic functioning.
Right.
Now, over the next few weeks, which by the way coincides with that time when we typically expect to see some antidepressant or anxiolytic or OCD-like, anti-OCD-like response, if that's the right word. So over those next few weeks, what then happens is that those 5-HT1A receptors tend to desensitize and they stop overreacting. We get normalization of that firing frequency. So the entire serotonergic network, if you will, establishes a new steady state. So this is, I know you're going to like this term because you use it a lot. This is a new allostatic set point here that only exists when the medication is present. And that's something that then has implications for when patients miss doses, but it also has really important implications for what happens when we may ultimately decide to taper off one of these antidepressant medications.
Yeah, we're also learning that this is not simply a deficiency of monoamines for some of the reasons you said. You can raise the serotonin within hours, and yet the efficacy takes longer. We now have medications that work with different mechanisms. So there's probably many different ways to influence, for instance, neuronal excitability and firing, network connections, regulation between, top and bottom, and so on. So there's probably a lot of different ways to skin the cat, if you will. And the fact is, because this is such a heterogeneous illness, frankly, some patients are going to do better with one of these than another. But again, we don't have that blood test or x-ray, Jeff. We don't have the biomarker.
No, we do not, but we're getting closer, Andy.
I agree.
And I think our listeners would really enjoy reading an article that came out recently. Maybe we can even put it in the link to this show. But it's a JAMA Psychiatry article by Zhao and colleagues. And what they did was actually administer SSRIs to patients, and then at different points in treatment, we're able to look at frontostriatal limbic connectivity associated with the acute administration and then the chronic administration as these patients started to see relief. And what, again, we see, not surprisingly to you and to our listeners, is that there's a normalization of activity within these circuits associated with treatment.
Well, another myth that I think we should just address head on is the myth of suicidality, that these medications somehow cause suicidality. We're talking about an illness that, unfortunately, one of the consequences can be suicidality. That being said, it could be that the wrong medication in the wrong patient could be a problem. It could be that we don't have the diagnosis correct and so on. But Jeff, let's talk about the boxed warning that all antidepressants have that the FDA put on them. Can you tell us a little bit about the history of that?
Yeah, I can. And I think this is really something we need to spend some time unpacking because I think this is something that really goes much deeper than a warning or the intent of that warning. What it really is a discussion about is the effects of fear and alarm. And if we go back to 2004, you remember that we had a single meta-analysis.
Yes.
And that meta-analysis actually used an older design, a fixed effect model. And interestingly, that's a meta-analysis that has not been replicated. Also, I think that something that's important is that there's a lack of any mechanism associated with that risk. But nonetheless, based on that analysis, the FDA issued a box warning on antidepressants regarding suicidal thinking and behavior. Now, that box was subsequently expanded. We can maybe talk a little bit about that later. But I think one of the things that's really important for our listeners to remember is that there were a number of folks who were very, very concerned about the implications and the effects of that warning. And they warned us at the time that there may be significant effects in terms of increases in suicidality.
Yeah.
And unfortunately, that guidance was probably somewhat prophetic, because what we actually saw was that there was indeed an increase in suicide rates among children and adolescents, and there was a decrease in the diagnosis specifically of depressive disorders.
Now, wait a second. There was a decrease in diagnosis. That might be news to our audience. I think they would understand there was a decrease in prescribing of antidepressants. But you're saying it became a don't ask, don't tell situation?
I really think it did. So essentially what happened was that suicide rates rose by 60% in untreated adolescents.
Oh, goodness.
So again, potentially making this link between a lack of treatment, maybe because of fears related to the boxed warning or suicidality myths, but that was associated with an increase in deaths, which I think is something important.
Well, this is the law of unintended consequences. I think the intention here was to provide an appropriate warning, just like you would about any side effect of a medication. But unfortunately, the unintended consequence, as you said, is that people got scared and stopped prescribing, stopped even looking for it and diagnosing. Now, I had on our podcast several months ago, I had our good friend Christine Moutier on, who is the Chief Medical Officer of the American Foundation for Suicide Prevention, and she's wonderful. And we had a great discussion about this.
And that was a great podcast. I listened to it as well.
I was going to recommend maybe some people should go back and listen to that. But one of the things that she agreed with me on, I've had a theory for years, is that one of the risk factors for bipolar disorder is early onset of depression. And interestingly, the data from Barbara Geller and colleagues at WashU in St. Louis was they quoted under 25. Well, what is the definition of a young adult here? It's 24 and under. Jeff, that sounds like the same. It's 6 of one, half a dozen of the other. So my point is that if your first episode is 24 or under, that triples the odds you're bipolar. And it's very likely it was not recognized or diagnosed in some of these patients. And we know giving an antidepressant unopposed monotherapy, not good for someone with bipolar. So I think one of the public health messages here should be we must screen every depressed patient for bipolar disorder.
Absolutely. And one of the things that I'd probably also emphasize here is that first mood episode may not be a manic or mixed episode. It may be a depressive episode. And as you know, bipolar 1 disorder is characterized, in fact, defined by having that manic or mixed episode.
Yes.
Andy, if I may, I'd like to mention one other study that I think is really relevant here. And this is a study that was published maybe 2 or 3 years ago in Neuropsychopharmacology. And it's a really interesting study because it actually looks at, using a large health registry, what is the incidence of suicidality, get this, before an antidepressant is actually started.
Interesting.
And what they found was the rate of suicidality actually increases prior to starting antidepressant. And then guess what happens when you start an antidepressant in all age groups?
I would hope it goes down.
It goes down, and it goes down in a statistically significant way. But one of the things that is really interesting is that decrease in suicidality is most significant in older adults, but it does decrease in all age groups as well.
Interesting.
So I think really one of the things that we probably also need to mention is that when we're talking with families in the office, particularly parents of children and adolescents in whom we might be considering an SSRI, the message should really be vigilance, yes, but fear, no.
Okay.
Because I think the real danger, as you nicely distilled from these studies, is untreated illness. Certainly we have to monitor closely, we have to follow up early, but we need to not let stigma or misunderstanding or mythology stand between a patient and an evidence-based treatment.
That's very well said. We're going to talk about side effects in a minute, but I have to tell you something a mentor, a friend of mine, Terry Ketter, once said. I was in an advisory board with Terry, and he was a very famous bipolar expert. And we were all arguing about the merits of a medication, pros and cons, and interpreting the data. And he just sort of in the middle just stops and says, it occurs to me one of the worst toxicities of our medicines is lack of efficacy. And I think when we're evaluating risk-benefit, we're too often looking at risk as a side effect. But what is the risk of inadequately treating our illnesses, Jeff?
I don't know that I can put it better than that. But I think really the larger issue here is something that we see pretty routinely. Avoiding a medication because of a potential risk probably ignores the larger proven risks of leaving anxiety or depression or OCD untreated. Right? We see academic decline, we see social withdrawal, we see actual suicidality.
That's right.
We see impairment in terms of families and loved ones.
We're also learning, Jeff, that these illnesses over time are not good for the brain. And we're learning probably the sooner we recognize, appropriately diagnose, and treat, we may literally be saving brain and improving brain function. We know over time, the more episodes of any of these illnesses somebody has, the harder they are to treat. And the less likely they are to come all the way back to where they were beforehand, premorbidly, if you will.
Absolutely. Absolutely.
So another imperative to consider when we're thinking about choosing medicines. We've talked a little bit about depression, Jeff. Let's talk a little bit about anxiety. How should we interpret these medicines for anxiety differently for depression?
Well, I think when we look at the anxiety and OCD versus major depressive disorder, particularly in children and adolescents, we see huge differences. Now, what's really interesting is this is not a difference in terms of medication response. It's often a difference in terms of placebo response.
Oh.
And obviously, if I'm increasing my placebo response and my antidepressant response stays the same, it looks like my antidepressants are less effective.
That's right. You lose your signal.
That being said, what I think is really clear in children and adolescents, and we can talk about adults as well, is that multiple randomized controlled trials, meta-analyses, clearly demonstrate superiority over placebo. Now, in anxiety and OCD, the effect sizes probably rival those seen in adults, at least for those two conditions. So the challenge really isn't lack of efficacy. A lot of this is related to study design and our ability to detect drug-placebo differences.
Yeah.
Now, I think when we look at the adult studies, in general, what we see is that for the anxiety disorders, particularly generalized separation and social anxiety disorders, we tend to see greater magnitude of effects than we do for major depressive disorder. And there are probably a lot of factors that really confound that. Some of this probably also relates to something we call omitted variable bias. So one of the things that we understand, particularly in depression, is that there are a lot of factors that really drive response. So we've looked, for example, in COMED at the impact of socioeconomic factors and other social determinants of health, which have, in many cases, sequoian effects on treatment response. Yet, if we don't know what's going on there or aren't measuring those factors, as we often don't in many of our clinical trials, we're not able to then control for those effects. And so what we do is ultimately end up with more noise obscuring our signal.
Yeah, you're bringing up another really important point we should have mentioned earlier in talking about, do medications actually work better than placebo? And that is the fact that a lot of this depends on the tool or the instrument I'm using to detect efficacy. What do I mean by efficacy? Many of these rating scales are symptom-based, and they're limited to a certain number of symptoms. But the fact is, we know getting better encompasses much more than just that. So certain medications may work especially well on some area that maybe we're not adequately measuring, and that would obscure the effect.
That's such an important point. And if we go to the anxiety world, most of our trials looking at pharmacologic interventions, whether it be benzodiazepines or antidepressants or even some of the second generation antipsychotics, they've tended to use the Hamilton Anxiety Rating Scale as their primary outcome. Now, the problem is, if we look at the anxiety disorders, we know a lot of the burden actually comes from symptom severity. So how bad are my gastrointestinal symptoms, my cardiovascular symptoms, my chronic worrying? What's the amount of that worrying? But a lot of impairment also comes from something called avoidance.
Oh.
And what's really fascinating is that the HAM-A doesn't measure functional impact. It doesn't measure avoidance as a result of my anxiety, which is, again, one of the hugest drivers of morbidity in these conditions.
You're right.
So again, really how we're measuring efficacy is something that I think is so important.
Yeah, I totally agree. And there's largely a disconnect between what we focus on. We're trained to focus on symptoms because you need certain symptoms to make a diagnosis. The rating scales to get drugs approved are symptom-based. But there's a disconnect between that and what the patient's drivers are and concerns about and their goals for treatment, which tend to be more quality of life and function, as you've said. Okay, let's move on to something else. And let's talk about the idea of psychotherapy and medication. And when do I use one? When do I use the other? How should I integrate and incorporate these in my thinking about treatment?
Andy, I think the short answer to this goes back to what we were actually just discussing, is that we have to match burden, not ideology. So if symptoms are mild or moderate and functioning is intact, maybe starting with psychotherapy is very, very reasonable. But when the distress, the impairment, the functional sequelae of having anxiety or depression or OCD are severe and function is collapsing or there's suicidality, I think we are in a situation where we can't wait weeks or months for a psychotherapeutic intervention to gain traction.
That's probably true. And a lot of times too, if the symptoms are too intense, people can't benefit because we know that depression and anxiety both come with a cognitive impairment component. And so maybe you need to kind of address that storm early, get that better, and then they can really engage meaningfully.
Absolutely. And I'm going to warn you, I'm going to go tangential here and put on my child psychiatry hat for a moment.
All right.
Because one of my favorite papers in child and adolescent psychopharmacology is a secondary analysis from the CAMS trial, which was a study of children and adolescents with generalized separation and social anxiety disorders, almost 500 of them.
Wow.
So in this study, patients could get sertraline plus cognitive behavioral therapy, or they could get cognitive behavioral therapy, or they could receive placebo. Now, one of the things that I'm noticing as you're looking at me here is that there is no CBT plus placebo arm. So which means if you're getting CBT, you know you're getting CBT. Now, one of the things that was so interesting in this study is that patients who had a primary diagnosis of social anxiety disorder, they did as well in psychotherapy as they did with blinded placebo. So again, it makes sense. If we have such severe aversion and discomfort in some of these social situations, and it makes it difficult for me to attend to what the therapist is saying, or I have so much distress about just being in the room with another person and feeling judged and so forth, that I'm not able to take in the components of the therapy, why wouldn't I actually start with a medication, lower some of that anxiety, and now allow the patient to better engage in the psychotherapy?
Yeah, I certainly agree with that. And I think, let's face it, in all of medicine, the best outcomes are not just pharmacologic alone. It's a combination of medicine, therapy, lifestyle. I know I'm fond of saying if I was treating diabetes, Jeff, I wouldn't just give you insulin and say, eat all the chocolate cake you want, right? I think all of our outcomes are better if we can use multimodal types of interventions.
Absolutely. And specifically, when we're talking psychotherapy and pharmacotherapy, I just want to say this explicitly. These are not competing camps. These are complementary tools, and they're working at different levels, often within the same circuitry, at least when we're thinking about anxiety and mood disorders.
That's right. You know, Jeff, every experience you have, listening to the sound of my voice right now, changes the chemistry in your brain. So I was taught that it's not an either or. I was taught psychotherapy is a biologic intervention, if you will. It's just working a little differently and certainly can be complementary.
I couldn't agree more. So, Andy, I think the second part of this whole psychotherapy or medication myth is something that we can actually bring some data to. So, we recently published a study that was a secondary analysis of a large NIH-funded trial looking at individuals who had received, or rather been randomized to and received psychotherapy, specifically CBT. And what we found was that after 3 months of CBT, when patients then had the opportunity to add meds if they'd not fully remitted, what happened was that very, very few patients actually added meds. And that's something we often refer to as the stepped care irony. Now, the reasons, of course, we tried to look at in the context of this study, and we certainly had a lot of variables that we could evaluate. But what we really think happened is that there was a sense of giving up. In other words, some families and patients develop hope fatigue. I tried the therapy, it didn't work, nothing will. And so one of the things that we were actually able to look at were patient expectations of whether the treatment would work. And we found that those expectations actually play a huge role. So families who entered CBT with high confidence in its effectiveness were more likely to try medication afterwards when CBT didn't work. Almost as if having believed strongly in one treatment kind of gave permission for them to try the next one. But those patients who had low expectations initially were more likely to disengage altogether. And so I think this is something that's really important in terms of how we talk about our treatments and how we frame expectations in our discussions with patients. The other thing that I think is really important, and we see this in adult trials with depression, we see this in pediatric trials with depression and with anxiety disorders, is that changing horses early is probably the best strategy. So if I'm not getting the expected degree of improvement early on, it's better not to just wait and wait and wait and hope and wait. It's better to do something different. Change the frequency of the psychotherapy, add the medication, incorporate something that specifically addresses sleep, do something different to intensify treatment.
That certainly makes sense to me. Yeah. Okay, I want to talk about adjusting expectations and addressing expectations. This is something I don't know that we do enough or well enough. And when I'm talking about expectations, I'm talking not only about expectations for efficacy, for instance, when can I expect the medicine to work? How might it work? What things might it work for? But also expectations of side effects. And people don't like surprises, and so we probably need to warn them about side effects. And something I don't know that we do as well, Jeff, is I don't think we take an inventory of what side effects are most troubling to you. I've had the experience where a patient will say that if I give them a menu, they'll say, whatever you do, doc, don't make me nauseous. I hate nausea. Well, that's going to inform my treatment decision and hopefully lead to a better outcome than somebody who says, for instance, I can't stand sedation. Don't make me tired.
Yeah, Andy, side effects are so important, and I think we often don't give them the really attention that they probably deserve. So I think when I'm thinking about side effects as I'm talking with a patient, and I work with a lot of patients with anxiety disorders, as you know, and so often, and this is borne out by the literature, they may be more sensitive to side effects than are individuals without anxiety disorders. But one of the things that I think is really important is how we frame this discussion.
Okay.
And so one of the things that I like to do, again, thinking about anxiety disorders and looking at the world through an anxiety disorder lens, is patients don't like uncertainty. Actually, clinicians don't like uncertainty either. And so one of the things that I think is sometimes really helpful is if I can frame through a little bit of psychoeducation why someone might be experiencing a side effect or why a side effect might happen. Well, let's look at the example that you gave, nausea. So if we look at many of our quote-unquote antidepressant medications, they have nausea as a side effect. Now, where does that nausea come from? Well, it comes from that increase in serotonin that we were talking about initially before we have those compensatory processes really going full tilt. And what happens is that most of the serotonin in the body is actually in those enterochromaffin cells in the gut. And what does it do there? Well, it regulates gastrointestinal motility.
Yes.
Which when we disrupt that, looks like nausea or a little bit of dyspepsia or a feeling of rumbling in my gut. And so one of the things that I would actually say is that as we're starting this medication, one of the first signs that you may see the medicine starting to work is your stomach may feel a little bit different.
Interesting.
And so again, talking physiologically about what the medication is actually doing in terms of the gut. Mm-hmm. The other thing I think is really important, and this is something that I learned back at the University of Cincinnati from one of my attendings, is how we use placebo or nocebo effects. And so I hear this all the time, and I'm sure you do as well. Give me a call if you have any problems. Give me a call if you have any side effects, right?
Yep.
I've probably said it as well. Sure. But what if we were to use that placebo response here? Again, we know some patients start to feel a little bit of relief early. Mm-hmm. We know that many of these patients will still give us an update. And in the era of electronic health records, it's really easy to message with our clinicians. And so one of the things that we might say is, give me an update in a week and let me know how things are going, even if you're already starting to feel a little better.
Oh, nice. Well, the nocebo effect is fascinating. Jeff, I've said for years that placebo causes headache because in every clinical trial, you'll say, and nocebo effect, just so people know, there's a placebo effect on efficacy. Nocebo effect means you're randomly assigned a placebo and you complain of a side effect that would be potentially attributable to a medication. Part of the issue there is we give people very extensive informed consent forms that list all of the known or potential side effects. Sometimes that primes the pump a little and plants a seed in your head.
Absolutely. And you did this earlier, so I'm going to take the opportunity to do this and plug a podcast from the Child and Adolescent series yes. on the NEI Psychopharmacology podcast. And it's an interview that I did with Dr. Catherine Dalsgaard, where she talks a lot about the cognitive factors that drive this nocebo effect in terms of patients' expectations that I will experience a side effect.
Yes. And I like how you sort of put a nice spin on this that, well, side effect might actually mean the medication's working. It's doing something, if you will. And that's going to help with adherence, which is always a challenge if people have side effects and they don't understand there's something you can do about it. Maybe they'll get better with time. Maybe we can adjust the dose. Maybe we can switch from morning to evening dosing and so on. So this open communication and shared decision-making is so important with our patients. Jeff, I want to go back to a myth that we mentioned, but we didn't follow up on, and that is that these medicines are going to cause a change in personality. Well, Jeff, what does that mean? Where does that come from? And what do we do about it?
Oh my gosh, that's a lot here. And this is getting towards the end of the podcast. Yeah. Oh my gosh. Yeah. So let's try to unpack this one quickly. Because one of the things that I think is really important, and I often have this conversation in the office, is that when I'm starting a medication to treat major depressive disorder or generalized anxiety disorder or OCD, I do not want that medication to change who you are. Because one of the things that is often problematic is we conflate normal human emotions with symptoms. So I want a patient to still be able to feel sadness when it's appropriate. I want them to still be able to feel anxiety. And I use 2 rules to evaluate anxiety. I want anxiety to be proportionate and when it's expected, right? I want a patient to have anxiety before their first date with someone. I want them to have anxiety before their first exam in college. Anxiety has an evolutionary function.
Of course.
Right? Human sadness is part of the normal human experience, and I don't want a medication to take that away. These are not anesthetics. They're medications to treat depressive disorders, anxiety disorders, OCD, and even PTSD.
I certainly agree with you, and I think where some of this myth might come from is the real fact that SSRIs in particular can cause some emotional blunting. And I think that what we need to talk to people about is how you said, this shouldn't change who you are. It could change your response or your feeling of emotion or expressing of emotion. If that's an issue, we need to talk about it because it could be a dose adjustment. It could be we need to switch the medicine. It could be we need to add something. I think giving people the understanding that there is something we can do about it is so important. And this gets to the heading of instilling hope, which of course is so important.
Absolutely.
What appropriate hope.
Absolutely. Absolutely.
Yes. All right. Well, you're right that unfortunately, and this always happens, Jeff, in our conversations, time has passed quickly and we're getting close to the end here. But I do want to leave people with some kind of take-home messages here. So what are some practical strategies our friends can use in their day-to-day practice, especially to address the misinformation that's out there? You know, people get a lot of their information now from TikTok and other sources. It's not just patients, by the way. Clinicians now, younger clinicians are using AI, for instance, in TikTok to guide decision-making. So how can we address misinformation?
Well, I think the first thing is really when this misinformation comes up, it's often not coming from a place of malice. And so I think in many of these situations, it is coming from a real concern. And I think validating and listening to that concern is critical. And I think that's important to do before actually correcting a misconception or busting a myth.
Okay.
But the other piece is that really kind of opens the door to having a very different conversation in terms of some of the things that we've already talked about that are really more nuanced in terms of what these medications actually do or don't do. And I think in ways what that does is actually make the science and the evidence more accessible for many of our patients.
I also like providing patients and families with more legitimate sources of information. For instance, the National Institute of Mental Health, or if we're talking about depression, the Depression and Bipolar Support Alliance. And I know for anxiety, there are organizations such as...
Right, the ADAA.
ADAA, I was going to say, yeah. And sometimes that helps to balance out these less legitimate places that they're getting some of this information. But Jeff, you said something wonderful, and I really love what you said about we need to first validate the experience and validate their concerns before we jump in and start saying, no, you're wrong, or myth busting, if you will. So that's a very important part of that clinician-patient relationship, of shared decision-making, and of having the best kinds of open communication that can lead to better outcomes.
But I think one other thing is really important, Andy. I understand why you focused on the patients, but I think it's really important for our listeners to remember that clinicians absorb misinformation too.
Oh, yes.
We're all swimming in the same media waters here. And so I think this is really a public service announcement here for ongoing education and humility and curiosity, which really are, I think, the best antidotes for these myths here.
Well, you just said two very important words, Jeff, that I resonate with, and I use this when I'm teaching students and residents, and that is, I've often said to be a good clinician is to be curious. It's to ask more questions, because after all, our data is not a blood test or measuring in blood pressure. Our data is how much information can we get from the patient? How comfortable is the patient sharing that information with us in a non-judgmental way? The second word you said is humility. I think we have to be humble in the face of the illnesses we treat, the neurobiology. There is a science, of course, to this, but there's a lot of art as well. So curious and humble, I think, is a nice take-home message.
Yeah, I really do think that's such an important point to end on here.
Jeff, unfortunately, I think we are getting very close to the end of the time, and I love that we have given some good take-home messages here. But if you could challenge clinicians to rethink one entrenched assumption about antidepressants, maybe something different from a public myth, if you could give them some final piece of advice here, what would that be?
Just one piece of advice?
You can give as many as you want.
So I think keep reading, keep interacting with colleagues, keep critically reviewing the literature. I think the other piece is really thinking about the actual evidence that we have. When we look at many of these conditions that we treat with antidepressants, quite frankly, they work and they're well tolerated. And I think clinicians would really do well to remember that, because I think that's something that often gets lost in this noise that we're talking about that really comes from all of these myths.
Yeah, I certainly agree. But is there any specific entrenched assumption or misperception that we should address?
So I think, Andy, if you're going to try to pin me down to one assumption, I think we need to rethink evidence-based. That's a term that gets thrown around a lot. And one of the things that we often lose sight of is the fact that that term evidence-based is pretty dynamic. It's not static. Our algorithms, our treatment approaches, they should evolve. They have to evolve with the data.
Yes.
And with our understanding of mechanism,
yes,
of tolerability, and of patient preference. In other words, good psychopharmacology, it's not just about following the evidence. It's really listening to that evidence and being part of that evidence and incorporating the art of psychopharmacology.
That's very well said. And perhaps I'd add one thing. All too often I see out in the field that people have their kind of go-to strategy, or they limit their universe of treatment options. This is what I always start with. This is what I always do. I think we have to really recognize, again, coming back to something we talked about earlier, the heterogeneity of these illnesses, both in the clinical presentations and in the underlying neurobiology. And the fact that we're getting more sophisticated, we are getting more tools, and I think really individualizing and learning to use these tools more appropriately might be very helpful to our patients. Jeff, this might sound strange to some in the audience, but in my training, we were not encouraged. We were required to use every different medication. Now, at the time, there was only 3, I think, FDA approved. I'm kidding, of course. But there were fewer. But the point was, we were strongly encouraged to try all the different medicines, learn how to use all these different tools, so that we did have more tools in our toolkit to maybe help more patients in a better way. So staying humble, staying curious. I think also don't set it and forget it is a very important point. In other words, don't just have one dose and that's it. Be able to dynamically adjust the dose of the medicine, the choice of the medicine. Am I adding or subtracting something over time? Because the illnesses evolve, as you said, over time.
Absolutely.
Great. Well, Jeff, I want to thank you. This has been tremendously interesting and helpful, hopefully. I hope everybody in the audience found it useful as well. We were Mythbusters today. That was a lot of fun.
That was so much fun. These are always fun, but this was especially fun.
Well, great. Glad to hear it. And I want to thank you for joining me, of course, today. And I want to thank you, the audience, for listening. And for more information on our podcasts and our other educational offerings, please go to our website, which is neiglobal.com. Thanks for listening.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.